Welcome to the deep dive. Today, we're tackling a really important topic, ectopic pregnancy.
Yeah, we've got this set of pretty detailed revision notes here.
Exactly. And our plan is to basically turn these dense notes into something, high yield, easy to remember.
Perfect if you're prepping for exams like the MSRA, or honestly, if you just want to properly understand this condition.
So, our mission, unpack these notes, pull out the absolute must-know facts, and give you that core knowledge efficiently.
We'll cover it all: definition, causes, risks, right through to management, all based on this material.
Let's get into it then, ectopic pregnancy.
Okay, so first things first. What actually is an ectopic pregnancy?
The definition in the notes is pretty clear, isn't it? It's when a fertilized egg implants outside the uterus. Simple as that.
Simple definition, but huge implications. And the material points out, overwhelmingly, the most common place for this is the fallopian tube. That's the typical spot.
Right, but it also mentions rarer locations.
It does. And this is important. While the tube is common, the notes say it can occasionally implant in the cervix, an ovary, or even out in the abdominal cavity.
Which are all non-viable locations, fundamentally. The notes are clear. Only an intrauterine pregnancy can develop properly. Anything else needs intervention.
So why does it happen? The etiology, the causes, the material suggests the core problem is something hindering the egg's journey down the fallopian tube.
Yeah, something getting in the way of that transport. The notes list things like damage to the tubes themselves.
Exactly. Damage, inflammation, maybe hormonal issues affecting how the tube works, or even just abnormalities in the tube's structure.
It all seems to point back to that pathway being blocked or slowed down somehow.
Which leads us nicely into risk factors. This is definitely high-yield stuff for revision. Who's more likely to have one?
Well, the biggest one highlighted in the notes is having had an ectopic pregnancy before. That significantly bumps up the risk.
Makes sense. Other things that damage the tubes are also key risks mentioned. A history of pelvic inflammatory disease, PID.
PID, yeah. That comes up a lot.
Or previous surgery on the tubes, or even just pelvic or abdominal surgery in general. Scar tissue, maybe?
Could be. And fertility treatments like IVF are also listed. The notes even give a figure about 3% of IVF pregnancies turn out to be ectopic.
Interesting. And then there are more general factors like older, maternal age, and smoking mentioned too.
No, I liked how the materials sort of categorized these risks, focusing on the mechanism.
Yeah, that was useful. It separates factors that specifically slow the egg's passage.
Right, so that includes the tube damage we talked about from PID or surgery, the previous ectopic history, endometriosis as well.
And interestingly, the use of an IUCD, the coil.
And the progesterone-only pill is mentioned there too, possibly slowing things down.
Then there's the other category, factors that just generally increase the risk, some overlap here.
Like assisted reproduction, IVF again.
History of pelvic infection, adhesions from infection or endometriosis, previous tubal surgery, and again, IUCD use is listed.
Okay, that IUCD point needs clarifying because it seems weird, right? How can something that prevents pregnancy be a risk factor? The notes actually address this.
Yeah, it's a crucial distinction. An IUCD is really, really good at stopping any pregnancy.
Okay.
But if pregnancy occurs with an IUCD in place, so a contraceptive failure, the conditions that allowed that pregnancy to happen, or maybe the device itself, make it much more likely that the implantation will be ectopic.
Ah, I see. So lower overall pregnancy chance, but higher relative risk of ectopic if pregnancy does happen.
Precisely. It's a detail worth remembering for sure.
Definitely. Okay, so moving on from causes to what actually happens inside the pathophysiology. When the egg implants in the wrong spot?
Well, the notes say it just starts developing there, like it would in the uterus. But the tissue, usually the fallopian tube wall, just isn't built for that. It can't stretch and support a growing pregnancy.
And the big danger, the reason it's often an emergency, is rupture.
Exactly. The growing pregnancy can literally tear through the tube wall,
causing potentially massive internal bleeding, which is obviously life-threatening. And the notes stress the embryo can't survive outside the uterus anyway. Prompt intervention is vital.
And anatomically, the notes give us the breakdown. Like we said, 97% are tubal, mostly in the ampulla or the isthmus parts of the tube.
And that smaller group, 2–3%, are interstitial, where the tube joins the uterus.
Correct. And then you have those really rare ones, cervix, ovary, abdominal sites, even old C-section scars. Knowing these exist is key for the differential diagnosis.
Right, the differential. So someone comes in, symptoms could be ectopic.
Wow.
What else needs to be on the list? The notes give us some common one.
Miscarriage is a major one. especially threatened or incomplete miscarriage. Symptoms can look very, very similar: pain, bleeding.
Pelvic inflammatory disease, PID again, can present with similar pain.
An ovarian cyst rupture can cause sudden pain too, or even something simpler like a UTI, or urinary tract infection.
Or appendicitis, depending on where the pain is located.
It really drives home that point in the notes. Any reproductive age woman with abdominal pain or vaginal bleeding, you have to consider ectopic until it's ruled out.
Absolutely critical. Okay, let's talk numbers epidemiology. How common is this?
The UK figures in the material suggest about 1–2% of pregnancies. Overall incidence may be around 0.5% of all pregnancies.
A more specific UK rate mentioned is 11 per 1,000 pregnancies.
What's quite stark is the mortality data. It has decreased, thankfully, down to about 0.2 deaths per 100 ectopics now.
Which is good progress.
But the notes add a sobering point. Some of those deaths are still linked to substandard care, delays, misdiagnoses.
It reinforces why being sharp on this is so important. The notes also touch on access issues for some groups like migrants or refugees, potentially affecting outcomes.
And rates after assisted reproduction, like IVF, seem quite variable. Notes say 0.8% up to maybe 8.6%.
Wow, big range.
And that really rare scenario, heterotopic pregnancy, having both an ectopic and a normal intrapreter in pregnancy at the same time. The incidence is given as somewhere between 1 in 4,000 and 1 in 30,000. Super rare, but adds complexity.
Okay, so how does someone actually present the clinical picture? What are the common symptoms according to these notes?
Well, the classic triad, sort of, is vaginal bleeding could be light, heavy, irregular, abdominal pain often sharp, often one-sided, and a missed period, usually with a positive pregnancy test.
Right, but then there's that classic sign, maybe not always there, but a real exam favorite.
Shoulder tip pain.
Yeah.
Yes, the notes highlight this. It's caused by blood in the abdomen irritating the diaphragm. If you hear shoulder tip pain in this context, ectopic should jump right up your list.
Definitely a good memory hook. And obviously, signs of shock pallor, tachycardia, low blood pressure that screams rupture, emergency.
Yeah. The notes also mention the history can be a bit vague sometimes, mimicking other things, which is why that differential list is key.
Other symptoms mentioned are dizziness, breast tenderness, sometimes urinary or GI symptoms too, and always asking about previous ectopics is vital.
On examination, pelvic or abdominal tenderness is common, especially adnexal tenderness pain near the ovary and tube area.
But there's that important caution in the notes about examining, right?
Yes, absolutely. Avoid vigorous palpation of an adnexal mass if you suspect ectopic because of the risk of causing a rupture. Handle with care.
Good point. Other potential signs on exam: rebound tenderness, cervical motion tenderness, maybe abdominal distension. The uterus size might be normal or slightly enlarged.
And signs of blood loss like pallor, tachycardia, hypotension, or even collapse in severe ruptured cases.
The key message from the notes seems to be positive pregnancy test plus pain, bleeding, or tenderness. That patient needs referring to hospital for assessment, period.
No question. So they arrive at the hospital, you suspect ectopic. What investigations are needed?
Well, first, confirm pregnancy. Seems obvious, but the notes stress a pregnancy test is step one for any woman of childbearing age with lower abdominal pain.
Then the big one, transvaginal ultrasound. The notes call this the most accurate method, the preferred diagnostic tool. It lets you look for an intrauterine pregnancy or potentially see the ectopic itself in the tube, check its size, look for a heartbeat.
Right. And blood tests are also key, specifically beta-HCG levels.
Yes, the HCG levels are crucial for diagnosis and deciding on management. There's a specific threshold mentioned in the notes.
The 1500 level.
Exactly. If the beta-HCG is over 1500 IU per ml, and you don't see a pregnancy inside the uterus on that transvaginal scan, that's highly suggestive of an ectopic.
Because you'd normally expect to see something in the uterus at that level.
Correct. And serial HCGs, measuring the level again after 48 hours, are really important for pregnancy of unknown location, or PUL. Seeing how the level changes helps figure out if it's a failing pregnancy, a very early normal one, or likely an ectopic.
The notes mention coldocentesis briefly, checking for blood behind the vagina, but state ultrasound and HCG are the mainstays now.
Definitely. So, okay, diagnosis is confirmed. How is it managed? The notes outline 3 main strategies.
First up is expectant management. Basically, watching and waiting.
But only for very specific situations, right? The notes say it's for small ectopics, less than 35 millimeter, unruptured, patient has minimal pain, HCG is low under 1,000, and crucially, no fetal heartbeat seen.
Why is that even an option?
Because, as the notes imply, some very early small ectopics just resolve on their own. The body absorbs the tissue without any intervention needed, but needs careful selection and monitoring.
Okay. Then there's medical management, using methotrexate.
Right. This drug stops the pregnancy cells from growing. It's an option for women who meet the criteria and, importantly, can reliably come back for follow-up.
What are the criteria mentioned?
Again, size less than 35 millimeter, unruptured, no significant pain, no fetal heartbeat. The hCG level often needs to be below 1500 IUL, according to these notes, though protocols can vary slightly. And importantly, you can't use it if there's also a normal pregnancy in the uterus, that heterotopic situation.
Are there side effects?
Yes. The notes mentioned potential abdominal pain, nausea, vomiting, sometimes temporary liver upset, so monitoring LFTs and hCG is vital. And a big point, women need reliable contraception afterwards for a few months because methotrexate can cause birth defects. Clear instructions are key.
Makes sense. And the third option?
Surgical management, usually needed for higher risk cases or if it's already ruptured. Laparoscopy keyhole surgery is preferred if possible.
When would surgery be the go-to?
The notes suggest criteria like size over 35 millimeters, significant pain or suspected rupture if you can see a fetal heartbeat, if the hCG is very high, over 5,000 IUL, or basically if the patient doesn't meet criteria for expectant or medical management.
And surgically, what do they actually do?
Two main procedures mentioned, salpinectomy, which is removing the whole fallopian tube with the ectopic,
Okay.
or salpingotomy, where they make a cut in the tube, remove the pregnancy, and then repair the tube, trying to save it, especially if the other tube isn't healthy or for future fertility. Choice depends on the situation.
Got it. Any other key management points in the notes?
Anti-D injection for rhesus-negative women having surgery,
Right. Standard practice.
and providing tailored written information and a 24-hour contact number. That's crucial patient support.
Absolutely. The notes also mention the importance of early pregnancy assessment units, EPUs. They often take self-referrals, especially for women with a history.
Yeah, streamlined access is key.
Oh,
Okay, so what about the outlook? Prognosis after an ectopic.
the good news, according to the material, is that most women over 85% are diagnosed before rupture happens now, thanks to better diagnosis with hCG and ultrasound.
Which allows for less invasive management sometimes, maybe preserving the tube.
But what about future pregnancies? The notes give some stats.
The risk of having another ectopic is definitely increased. The notes say somewhere between 10 and 20%. That's quite significant.
Yeah, something patients need to know. But what about the chance of a healthy pregnancy later?
That's actually pretty good. The notes quote figures of 64% to 76% chance of a subsequent intrauterine pregnancy. And interestingly, future success rates seem similar regardless of whether management was expectant, medical, or surgical.
That's reassuring. Okay, finally, complications. What are the big risks?
We've mentioned it a lot, but the most serious is definitely tubal rupture.
Leading to hemorrhage.
Exactly. The notes state clearly, delays in diagnosis or treatment dramatically increase the risk of rupture, severe bleeding, shock, DIC, that's disseminated intravascular coagulation, and potentially death. It really highlights the urgency.
Are there other complications?
Yes, potential infertility is mentioned, either from the damage caused by the ectopic itself or from the treatment, like having a tube removed, salpinectomy.
And recurrence, we already touched on that higher risk of future ectopics.
Right. And surgery itself isn't risk-free. The notes list potential complications like bleeding, infection, damage to nearby structures, bowel, bladder, ureters, blood vessels.
So important interventions, but they come with their own potential issues.
Definitely. So that takes us through the core content of these notes: definition, causes, risks, how it happens, what else it looks like, the stats, presentation, tests, management options, outlook, and potential problems.
It's a lot to take in, but breaking it down like this helps. So reflecting on all that, what's one thing that really stands out to you from this deep dive?
Good question. Maybe it's the importance of those subtle signs, like the shoulder tip pain, easy to dismiss, but potentially critical. Or maybe understanding the why behind those hCG cutoffs, like the 1500 level for ultrasound visibility. It makes the guidelines make more sense. What about you?
For me, I think it's that connection between risk factors like PID or previous surgery and the actual mechanism of the damage slowing down the egg. And also that sobering reminder about substandard care still being a factor in mortality sometimes. It shows we always need to be vigilant.
Yeah, absolutely. It's a condition that requires real alertness.
Well, that wraps up our deep dive into ectopic pregnancy based on this set of revision notes.
We really aim to pull out those high-yield facts, connect the dots, and hopefully make it a bit clearer and easier to remember.
Hope it helps consolidate your knowledge, whether you're revising or just wanting to understand it better.
Because getting these details right is so important for patient safety and, of course, for exam success.
If you did find this useful and you're prepping for the MSRA, there are more resources out there.
Absolutely. You can find a whole load more revision notes, practice questions, things like that over at pastmsra.com and freemsra.com.
That's pastthemsra.com, PASSTHEMSRA.com, and freemsra.com, FREEMSRA.com.
Definitely worth checking out.
Until next time, keep learning.